Respected jury, my colleagues, I'm Dr. P.T. Alexander. I'm from CMC Vellore. I'd like to present a paper that was published this year in Annals of Indian Academy of Neurology. We had done a study on paraneoplastic neurological syndromes. Now, to introduce to you, what are paraneoplastic neurological syndromes? It's a heterogeneous group of disorders associated with cancer, but not related to the primary, the mets, or any side effect. Now, most of the literature on PNS is from Western data and mainly on Caucasian population. There was no large studies except for two in 2015 and 2018 in India. So our extensive cohort analyzed multiple aspects of PNS. Methods, it was a retrospective study spanning 11 years from 2008 to 19. Consecutive patients diagnosed with PNS were taken above the age of 16, approved by our IRB. We identified PNS as per the gross criteria as classical and non-classical, definite and possible. Classical are the typical presentation of the PNS with a cancer in the background. Non-classical are atypical presentation with or without a cancer in the background. The antibody classification we used, onconeural or the intracellular antibodies and the cell surface antibodies. Onconeural will be classified as well characterized and partially characterized as per the literature with associations for the tumors. Treatment and outcomes, all the patients received treatment for a primary tumor if they had one. Depending on the tumor, the treatment is selected, and immunotherapy, both first line and second line, depending on the discretion. Functional status as the outcome was classified with the MRS at admission, 6 months, and last follow-up that we had. A good outcome was an MRS that picked up by 1 at 6 months. Statistical analysis, descriptive statistics by proportion, mean, and median. Chi-square were used, logistic regression was used. Survival rates, survival curves was by Kaplan-Meier, and we used SPSS version 22 for statistical analysis. Results, we had a cohort of 97 patients, a female to male ratio of 60 to almost 40 to 60, median age of less than 55. Definite PNS was about 3/4 of the cohort, and 1/4 was a possible PNS. The distribution between the central nervous system and peripheral nervous system involvement was almost 50 to 50. Multifocal involvement is more than one PNS isolation in the patient was about 12.3%. Usually, mostly associated with the paraneoplastic cerebellar degeneration associated with LEMS, peripheral neuropathy, and obstructive myoclonus syndrome. Presentation-wise, the most common was a subacute presentation, more than 50%, followed by chronic by 30% and less than 20% acute presentation. The classical syndromes, the most common that we got was a PCD, the paraneoplastic cerebellar degeneration, and the non-classical was a sensory motor axonal neuropathy. Tumor profile among the patients, tumors were detected in about 2/3 of the total population. The most common being lung cancer, followed by ovarian cancers, both less than 20% individually. The cancer was detected concurrently in PNS in almost 3/4 of the population, which is very significant because once you catch the PNS and diagnose it correctly, you've got the cancer to be screened for. The antibody profile, the anti-Yo and anti-MAR2 were the most common in our study, slightly contrary to what the European or the Western studies had shown till now. The same, as I mentioned, the most common were the lung and the ovarian cancers, and the antibodies most common was the Yo and the MAR2. The treatment, all the patients with the tumors received a primary treatment for the malignancy. Additional immunotherapy was given for more than 50%. In a subgroup without, that is of PNS without the tumor, we had given additional immunotherapy in more than 2/3. The treatments were the same, first line and the second line as previously mentioned. Now it's follow-up, 6-month follow-up, we had more than 50% patients who had improved. A mean duration of total follow-up for our patients was almost two years, of which at that point of time also we had more than 1/3 who had still had a good MRS compared to a few more who had died compared to the initial 6-month follow-up, mostly because of cancers or complications. Now, the most important things, from all those who received immunotherapy, 75% showed an improvement in outcome at 6 months. Those with tumors, a good outcome was seen again in more than 75% who received an additional immunotherapy than only the primary tumor treatment. As you can see here, the NMDAR are the ones who had from the first to the second one, which have improved. The blue line indicates improvement in MRS on follow-up, whereas the others, Yo, MAR2, and the WHO antibodies had worsened on follow-up. The same predictors of good outcome as per the study was the statistically significant ones were the ones that's underlined, the temporal profile being acute or subacute, Immunotherapy adjuvant is given other than the cancer treatment. MRS less than 3 at presentation, and absence of metastasis at presentation. The mortality predictors were, again, statistically significant. Those were the presence of malignancy and metastasis at the time of diagnosis. Now, for the discussion, we have a shortage of studies for the PNS in India and as well as abroad. The ones in our study that we picked up, which are not there in previous studies, is a high proportion of non-classical syndromes, multifocal involvement, improvement with immunotherapy. Now, lung and ovarian cancers were the most common, but most important to note is that the PNS preceded the tumor symptoms by almost 75%, which gives us a chance to pick the cancer before it is even set in, or it's even metastasized. Anti-O and anti-MAR2 are the most common antibodies. The associations with the diseases, anti-O with PCD and ovarian cancer, anti-NMDA antibody with autoimmune encephalitis and ovarian teratoma. Now, anti-O and anti-WHO were relatively refractory compared to anti-NMDR, which was better with respect to treatment. Immunotherapy benefits patients with both cell surface and intraneural antibodies was the conclusion in our study. Now, to conclude, high index of clinical suspicion is very important to catch the PNS. Paraneoplastic antibodies and cancer screening are important for the diagnosis, and immunotherapy will almost certainly improve the patient. Finally, the approach that we thought of, you have a suspected PNS, you classify as clinically as classical and non-classical, you do a tumor screening, imaging, you do an antibody screening, tumor present, antibody present, treat the tumor, immunomodulate. Tumor present, antibody absent, treat the tumor, immunomodulate. Tumor absent, antibody present, continue tumor surveillance and immunomodulate. Both absent, continue tumor surveillance. Do not let go. Limitations in our study, retrospective study, antibody screening could not be done in the initial years of the study, and the treatment patterns were heterogeneous, often dictated by restraints of patients, things like that. Now, to quote Professor Sarosh Katrak, who had written an editorial commentary on the same study that we had, in spite of all these limitations, the study should be considered as a seminal study of PNS in India. Why do we do it? This is the first author, Dr. Ashish Vijayaraghavan, who is now in Sri Chitra, and with a patient who was there in the ICU with one of these conditions for 3 months on tube, cognitive decline because of a neuropsychiatric illness. This is a 24 months of follow-up. Cognitive improved to almost marker of 29/30. She's almost back to normal. That's why we have to do it. This is our team. All the authors listed are here, and our boss in the middle, Professor Matthew Alexander, our teacher. Thank you very much.
Thank you, Doctor, for your presentation. The topic is now open for discussion.